I wonder if either of you or both of you have any thoughts around unique things that you've implemented that have allowed you to really connect and communicate with your patients in spite of these time limitations. Are there any unique things that you all have implemented in real time, like face-to-face, when communicating with patients?
So I would say we did a pilot study that has not been implemented full time, and really I think we're still working on how to best implement something like this. But we did a pilot study using sort of educational materials and this whole sort of pathway and educational system in coordination with our nurse navigators, where you could send sort of a prescription to the patient of reading material or of educational material as they're going along. And so with the idea that early on, that one of those prescriptions would be more information about molecular testing and biomarker testing, decision-making, all of those types of things. We did a small pilot study to incorporate that, which on the surface is fantastic, right? But it was surprisingly challenging to actually implement. And I think that was, we were doing this again in collaboration with one of the researchers, the nurse researchers at our institution, and we hit more barriers than expected, because I think we all, as you say, we all want to educate, we all want to make sure that our patients understand and get the information that they need. But the practicality of doing that really successfully and in a streamlined way, but that's also consistent across providers, across the institution, it's a challenge.
Yeah, I can imagine. Are there any plans to extend the pilot or to maybe modify it based on what you all learned from the initial study?
I think it's certainly in discussion about how to best implement something like this. Part of that is again, sort of systems change, right? So the role of the clinic nurse, the nurse navigators has changed a little bit. And so even how we envision implementation is going to need to shift somewhat.
Wonderful. What about you, Dr. Bazhenova? Any pilot studies or any other maybe tips and tricks that you employ independently?
We haven't had any pilot studies, but I think the more I think about it, so the challenge of discussing those molecular testing with the patients is the fact that a majority of those molecular testing discussions happen in stage 4 patients, right? And majority of those discussions happen during the first visit for a patient with stage 4 lung cancer, where we just discussed that this is an incurable cancer with limited life expectancy. And then how much does our patient actually absorb? Anything else we said afterwards is still remain to be seen. And I actually have seen, when I talk to the patient, because they are so understandably fixated on their prognosis and survival, because it's going to affect their lives, that after that, my patient asked me question that I know I've discussed it already, because I have my spiel. I just tell the same thing to everybody. And I think now kind of thinking about it out loud after during that discussion, and maybe, we could set up another appointment with a nurse practitioner afterwards, that after the patient kind of already digested all that information, to go over again, the management of the molecular abnormalities. And one thing I actually want to highlight and build upon something that Dr. Bauman said before, that in those patients, we actually usually wait for the molecular testing to come back before we start their therapy. And it is much easier to just prescribe chemotherapy, immunotherapy for those patients, right? But then you're going to run into issues of toxicity, because if you gave immunotherapy before you give, for example, EGFR TKI and some ALK TKIs, you can actually going to run into toxicity, and you can permanently prevent your patients from continue on tyrosine kinase inhibitors. And so that's why this is an information that not all oncologists, especially those who practice in a tobacco belt where they don't see a lot of oncogenically driven patients, they might not be aware of that. And I think, how do we pass that information to the physicians? And also, how do we pass that information to the patients, that there is an easy way, but easy ways in this situation is not the right way?